Good morning, everybody, again, and a very warm welcome to today's webinar on the new European legislation on digital health data. And from the Europe region, we are delighted that you, the member organization colleagues from across Europe, have joined us today. And as Aitor already said, so please write down your name and country in the chat box. So your presence shows how important and timely this discussion is for our profession. And as you know, the European health data space was adopted last year by the European Parliament and the Council. It is a landmark development that will shape how health information is shared, accessed, and protected across the EU. So implementation will take place gradually, but its impact will be felt in every member state and in every health profession, including physiotherapy. So for us, this is not only about digital infrastructure, it's about the way we practice, how we collaborate with other professionals, and how we safeguard the trust of our patients. It also raises questions of responsibility for our associations, how to inform, guide, and support members as the new framework takes shape. That is why today's session is valuable. We will hear the results of a recent survey on physiotherapist awareness of the EHDS, and we will have a chance to discuss what these changes mean for our profession. We are honored to have with us Mr. Owe Langfeldt from the EU Commission DG SANTE. He will share direct insights into the EHDS legislation and its expected implementation. It is an opportunity for us to hear firsthand from the Commission itself. I would like to thank the members of my Advocacy and EU Matters Working Group for putting together this webinar, and I encourage all participants from the member organizations to actively engage in the discussion at the Q&A, because preparing together will make our profession stronger and better positioned for the future. There is some housekeeping, so please mute yourself during the presentations, because you will have ample of opportunity to interact afterwards, either through the chat or by raising your hand and being allowed to speak. This meeting will be recorded and it will be uploaded afterwards on the region's social media platforms. And with that, it is my pleasure to hand over to Adérito Seixas from the Advocacy and EU Matters Working Group, who will begin by setting the context and presenting survey findings. Thank you.
Hello, everyone. My name is Adérito Seixas, and I will be presenting the preliminary results of a survey that the Advocacy and EU Matters Working Group has issued this year. The goal was to understand the European landscape regarding the use of patient summaries, digital records, data access, and data sharing in physiotherapy. We have invited all our member organizations to answer the survey, and we got 33 answers, 6 of which were not valid. Therefore, the results I'm going to share today are from a pool of 27 valid answers. The answers were collected mainly from leadership and executive roles, professional and technical roles, and some administrative roles. So we are confident on the reliability of the results. We started by asking which essential elements should be included in a patient summary specific to physiotherapy to share digitally with other healthcare professionals. Interventions, treatment goals, and diagnosis are the most considered elements, followed by outcomes and functional status. However, member organizations reported heterogeneous terminology and a wide range of suggested elements, which could cause problems if the aim is to achieve some sort of standardization. The median number of elements suggested by member organizations is 6, but as we can see, there is a significant variation in the number of elements suggested. The analysis reveals that while basic elements like diagnosis and interventions are well recognized, for instance, the ICF framework and valid outcome measures are rarely mentioned, suggesting potential gaps in standardization. There is room for improvement in incorporating standardized frameworks and validated outcome measures across different countries. This is a very important point in terms of managerial autonomy. The data also reveals that about 78% of the responding countries are not currently fully using standardized patient summary formats for physiotherapy, while only about 22% have implemented them. This reinforces the idea of significant room for improvement in standardization across European physiotherapy practices. A significant digital divide in physiotherapy record keeping is also clear. Only 11% have universal official digital PT records. 48% have no official digital records at all, and 41 are in various stages of partial implementation. The partial implementation show diverse approaches, from sector-specific adoption, public versus private, to institution-dependent usage, highlighting the need for more standardized national policies in digital health record adoption for physiotherapy. There are some more common patterns in partial implementation. For instance, many countries have reported that physiotherapists have a standalone digital physiotherapy record that does not connect with the patient file accessible by the GP. Sometimes there is a mandatory inpatient discharge document to be uploaded to the National Health Information System in order to ensure data interchangeability, but not yet implemented for outpatients. Institutions within the National Health Service and some large private healthcare units have implemented official digital physiotherapy records, but this is not valid for home-based intervention or smaller private practices, for instance. Information is shared between public institutions, but not between private institutions and between public and private institutions. So sometimes it's not still mandatory to have digital records in some countries. Some physiotherapists use digital records, but sometimes they still use records on paper. Regarding familiarity and the implementation of healthcare data standards and terminology, such as Németh, LOINC, ICD, FEAR, and ICHI in physical therapy records and practice, the survey reveals significant variation in healthcare data standards adoption across European physiotherapy organizations, with room for improvement in knowledge sharing and implementation support. There is an equal split between, we have something about 33.3% of countries have no familiarity and 33.3% having partial implementation. Only 8% are planning to implement in the near future, suggesting that the countries may remain not using them or advance for partial or fully implementation. So among those reporting partial implementation, there is large heterogeneity in usage. Adoption by physiotherapists is largely variable and higher in the public system. Some of the standards and terminologies are not prepared for the particularities of physiotherapy, which is an important limitation in usage. Regarding record sharing with other healthcare providers, considering the 14 countries that said yes or partially yes to the question if physiotherapists are in your country currently using a standardized patient summary, 50% declare sharing with other healthcare providers, and 36% declare that only in some cases the records are shared. Many countries share digital physiotherapy records for multiple purposes simultaneously. Some countries noted different sharing patterns between public and private sectors. For instance, in the public, more for information sharing and referrals, and in private sectors, more for reimbursement. Some countries reported using records for all the listed reasons, including reimbursement in private practice. But very few countries emphasized patient safety and treatment quality as the driving purpose. This analysis shows that the information sharing and referrals are the dominant purposes, while reimbursement and administrative uses are less common, but still significant in certain healthcare systems. For those answering yes or partially yes to whether they use standardized patient summary format, almost half do not share the records with patients, which is quite alarming. Only 36% report sharing records with patients. And when asked for what purposes the digital records are shared, the most common answers are information sharing about treatment details and progress, exercise sharing to provide patients with their exercise programs and instructions, and appointment managing for scheduling, reminders, and appointment-related information. When asked if physiotherapists have digital access to relevant clinical information from other healthcare providers, only 2 member organizations report that physiotherapists have full digital access to relevant clinical information from other healthcare providers. And on the opposite side, 7 member organizations state that physiotherapists do not have digital access to relevant information. Regarding the barriers preventing clinical information access, the analysis revealed that legal and legislative frameworks and barriers related to technical and financial factors are the primary obstacles preventing physiotherapists from accessing clinical information across Europe. These systemic issues may require coordinated policy and technology solutions at national levels. So the top barriers are technical and financial. Then we have legal and legislative barriers affecting 52%. And the third most important barrier is the resource-related constraints. When asked to provide additional refinements and details, there are 4 key insights that were mentioned. We clearly have some sector fragmentation. The public versus private reality creates fundamental barriers that go beyond simple technical issues. It's about completely separate ecosystems that don't communicate at all in some situations. Professional hierarchy issues are also a concern. Several countries explicitly mentioned that physiotherapists are deprioritized compared to doctors and nurses in system access and policy decisions. We also have infrastructure fundamentals missing, so basic building blocks like national patient identifiers and unified record systems are absent in key countries. And cultural and organizational resistance. Beyond technical barriers, there are cultural hindrances within professions to adopt new recording and sharing practices. These insights show that the barriers are more complex and systemic than initially apparent, at least for me in the beginning, involving fundamental healthcare system architecture, professional hierarchies, and sector-specific challenges that require coordinated policy solutions. To conclude, across Europe, digital transformation in health isn't coming, so it's already here. We need to be aware that digital transformation matters for patients, clinicians, and physiotherapy services. Physiotherapy can't stay on the platform while the train pulls away. So we need standards, accessible data, and appropriate data, workflows, skills, governance, and funding. Our survey highlights that we are at different starting points. That's okay, but we need to be aware of this, and the Europe region of World Physiotherapy is ready to support our member organizations by connecting them and facilitating these discussions and bridging this gap. And that's why we are here today as a starting point. Thank you.
Very nice to meet you. And let me just jump right in and hope I don't run into technical issues here. So what is the EHDS on one slide? Because I could talk about this for several hours, but I'm going to give you the short version. We have 2 main strands here and 1 supporting strand. Primary use, that is to say the use of data for the delivery of healthcare, where we are improving patients' access to their own health data and ensuring seamless exchange for the continuity of healthcare, particularly also in cross-border situations. That's the first main leg. Second main leg is secondary use, so the use of making available health data for research and other public interest purposes in a safe and secure way, where we are creating obligations on what in our slang then we call health data holders, so healthcare providers and certain other entities, to make data available in a anonymized or pseudonymized form. And there is a whole process around it that I'll quickly touch upon later. And the third one, which supports both of these legs, are requirements for electronic health record systems. There we are doing a bit of, can call it classical product legislation that enables that to make sure that certain information systems used by healthcare providers can become more interoperable. Product legislation, think of it like rules saying cars must have seat belts, these type of things. If you want to, as a provider of such information systems, you want to sell them in Europe, you will need to ensure certain things, including interoperability. So On the primary use, which is what I'll be mostly focusing on in my presentation today, how we're going to do that, well, strengthening patients' rights. To do that, we have well, member states will have to create what is called in text electronic health data access services, which have, let's say, two sides of the same coin. One for patients and one for health professionals. And we're also ensuring that you can have, or that this works in cross-border cases, for which we will be building on the current voluntary My Health infrastructure, but by turning it into a mandatory system. What is quite important, and I also saw that in Adérito's presentation earlier, here I'll have to go into a short legal aside. That is under the treaty, so basically our constitution saying what can the European Union do and not do. Our role in healthcare is actually quite limited. So there are, of course, things like pharmaceutical legislation or medical devices rules, but on other things, particularly the internal organization of healthcare systems, that is reserved to the member states. So what we're saying in the EHDS on the primary use side is explicitly not you need to have electronic records, but what we're saying is that if you do have electronic records, here are some requirements on their interoperability, because that has an impact on the cross-border sites, and then for these types of things to make sure that union citizens can easily live, travel, work abroad inside the EU. There we then have a hook, and similarly for the access of people to their own data, where we're more on the data protection side of things and people's rights in that framework, there we have a, let's say, stronger mandate as European Union. So what are the benefits of this better access and better sharing? Of course, on the patient side, quicker, easier, and also quite importantly, free access to their own electronic health data in a certain number of defined priority categories. It'll also be easier for them to share them with health professionals, including cross-border, and also on the other rights, such as seeing who accessed it, we will provide easy ways for them to do that. Or nice and fine, what's in it for you as health professionals? Easier and quicker access to patients' data, including in the cross-border situation, and then the European electronic, I always stumble on this one, European electronic health record exchange format, and for the rest of my presentation, just the format, which will facilitate data sharing across systems by increasing interoperability. And while our main hook here is the cross-border part, I mean, if a healthcare provider in member state A can easily provide data in a format that a different healthcare provider in member state B can read, it should also help inside the same member state. So what are those priority categories? We have two groups here. One, and that it will, so first one, patient summary, so the short overview of the medical situation of a person, their medical history, then electronic prescriptions and dispensations. And in a second group, medical imaging studies related imaging reports, test results, discharge reports. The difference between those two groups is the moment in time by which the provisions relating to them become applicable. Basically, the first group that will start to apply, and I'm getting on to the application timeline at the end of the presentation, but to quickly jump ahead there, exchanges of the first group will start at the end of the first quarter 2029, while for the second group it will be 2 years later, so end of first quarter 2031. All of these to be exchanged in the exchange format. What is the exchange format, or rather, what will it be? Yes, it will be a description for the format, how to do that, and it will be done using an implementing act. Again, in EU legal lingo, if you compare that to your national systems, sometimes there in the law you would have the law adopted by Parliament saying out the broad lines, and then saying, and these details are to be set out in a ministerial decree or similar instrument. And on European level, the, let's say, functional equivalent to those things are implementing acts, where the Commission is given an empowerment to adopt them. There's a bit of a process behind to ensure also the involvement of member states there, but I'm not going to bore you with those details now. So on these access services, on the patient-facing side, well, to be member states to establish that. Whether they do one, whether they do several, that is their choice. As I mentioned, internal organization of healthcare system is for the member states, but basically they need to make it happen. What's also important there is that while in some countries you do have a more centralized storage of records, while others are more, let's say, federated or dispersed, we are agnostic on that aspect, on, let's say, where the data are behind it. Again, that's internal organization. We just think, well, you need to find a way so that people can, let's say, in a single window, access it. Whether you do that by pulling it together from different sources, or if you have it all in one source, that is their choice. And also these services should be interoperable. For that, we will provide technical specifications. Now, again, on the health professional facing side, so that would allow health professionals, including you then, to access the data in the priority categories of patients under your treatment. On authentication, so how would you log in? We have a link to the EHDS regulation, so the main framework for digital identity management in the EU. It could be one of those, or it could be other electronic identification that will meet specifications to be adopted. So what are the rights of natural persons in these access services? They can access the data, they can download a copy, view who accessed it through the service. So this is the what I mentioned earlier on the health professional facing side. If so, for example, think ahead in the future, you get referred a patient by their general practitioner, and then you can get some of the information of, let's say, their background, the referral, via these services. You can pull it from there. The patient, when going to the access service, would then also see, okay, they, my physiotherapist pulled these off my records. That makes sense. I'm going to see them the first time later today, so they're reading up on my file. Makes perfect sense. And there's a couple of other functions there that people can use. So this is on the side for really the patients on how this will help them. And on the health professional side, as I mentioned, there's the access here via these services, which should also increase your ability to get the data that you need for providing the best treatment and providing continuity of care. So if, right, yes, okay, it's just a bit slow. On the cross-border part, there, what we will be doing is setting up an infrastructure called MyHealth@EU. And I admit that the naming and labeling here is a bit confusing because there is already right now something called MyHealth@EU as voluntary cooperation under the Cross-Border Healthcare Directive, where some member states already are live and exchange certain data. Those are the ones in dark blue. 60 member states are alive with at least one service. So, for example, patient summaries or prescriptions. 10 more are expected to go live with their first services soon. And the ones in light blue, so the ones that are expected to go live are like, let's call it sky blue, medium blue, and the ones in pale blue are the ones that are still a bit further away for going live. So for the exchanges and the cross-border exchanges in primary use under the EHDS, we'll be basically further developing that infrastructure by, first of all, instead of having it a voluntary cooperation where member states may or may not participate, turning it into a mandatory system where they have to. And then we'll also be providing additional services and new data categories that can be exchanged, that will be able to be exchanged through this system. The current MyHealth@EU only supports what is this first group of priority categories, so patient summaries, prescriptions, and dispensations. So much on the primary use side. Now moving over to secondary use, and there very quickly. So what are we going to do there? We're setting up common European rules on who has to make which data available for which purposes under which conditions, meaning that we will create obligations on health data holders, so largely healthcare providers, to, in the first place, describe the data sets that they hold, provide these descriptions to new public authorities to be established, what we call the health data access bodies. These health data access bodies will collate these descriptions into a dataset catalog, make that available, and then researchers or also certain public sector bodies as part of their mandates can apply for access to these data. The health data access bodies will be acting as, let's say, the orchestrators of this. They will assess applications against the criteria in the EHDS regulation. So, for example, is the purpose for which a prospective user wants to access the data one of the allowed purposes under our framework? Is the data limited to what is really necessary to answer their research question, and so on? If they come to a positive decision, then they issue a data permit, which then both triggers the obligation on the health data holder to make the data covered by the permit available. They provide it to the health data access bodies, who will then prepare them for use by the user in a secure processing environment. So we're also not giving over the data here now. enjoy. It will always be, let's say, in a controlled environment to make sure that users don't, in short, do things they shouldn't be doing. An important thing here is that in the preparation of the proposal, let's say, of course, the main addressee of the obligation to make data available people were thinking of were entities, well, hospitals, let's say rather big healthcare providers. If you imagine, a hospital, lots of data about lots of people, while small healthcare providers, think general practitioner, or indeed a physiotherapist just operating on their own. There to provide the dataset description and the amount of data that could be made available might not be worth it. So that is why we have an exception for micro enterprises. So below, I think, 10 employees, certain limits on turnover. And those very small entities will be by default excluded from the obligation to make data available. That on a very short overview on what we're doing on secondary use. And now I mentioned it a bit already, the overall timeline for application. It is quite a long timeline, but given what I said about the infrastructures that we'll be setting up, I mean, there is a lot of work to do. Hence this longer timeline. The timeline was, as you can imagine, one of the key, or one key aspect during the negotiations, where, I guess you can guess between Parliament and Council who wanted to have longer transition periods. So the text was published in the official journal in spring this year, entered into force, but important thing, entry into force and applicability, two different things. Applicability as in the actual obligations on, for example, healthcare providers to connect to the national contact point for the health access services, or in secondary use, the obligation on holders to provide the descriptions of the data. All of these things will kick in quite a bit later. So on primary use, so exchange of the first group of priority categories, patient summaries, electronic prescriptions and dispensations, that, as I mentioned in the beginning, is going to kick in end of March 29, 2 years later, to be extended to the second group, so medical imaging studies, test results, discharge reports. On EHR systems, so less relevant for you, but for more relevant for the software companies that actually provide those systems. There, at the same time, their requirements to only sell compliant products will kick in, aligned for the depending on what kind of data the system is dealing with. And on secondary use, we will also have the secondary use in general, so the obligation for holders to provide the descriptions and the ability for kick in also end of Q1 29 for most of the secondary use categories, while for some of the data categories that will have to be made available, there are again 2 additional years. That is, for example, about certain genomic data, also because there the legislators felt that there's time for a longer transition to prepare. On secondary use, even later, there's a possibility to connect third countries to some of the infrastructures there. But as you see, this is really 2035 far off, so I'm no need to go into that now. What I can say, talking about third countries, and since I'd seen from your member states that on non-EU countries and how all of this matters for them, 2 small remarks. One is that this text is flagged as having a EEA relevance, meaning that the process for incorporating it into the EEA agreement is ongoing, will happen. So once that is done, Norway, Iceland, and Liechtenstein will become equivalent in treatment to the member states here. And for other third countries, well, this is just one thing Europe does on its own, but there is, particularly also in primary use, which I think is why it's interesting to mention that here, a possibility that third countries can in the end join the MyHealth@EU exchanges, provided that, well, basically they're able to send and receive the data in the same format and provide certain safeguards on how it would be used. And that is to join those exchanges so that, for example, or let's say their residents, if they need care while being on vacation in the EU, the doctors in the EU could get the information from back home and vice versa. So that is something which can also be of interest for, yes, like particularly neighboring third countries. On this, well, this concludes my presentation. Thank you very much for listening, and happy to take any questions you may have. Thank you.
Thank you, Mr. Langfeldt, for this elaborate presentation. And I reckon that there are a couple of questions which we will hold after the next presentation. I'm now going to introduce Marloes Meurs, who's also a member of our Advocacy and EU Matters Working Group, and she will tie this down to the implications towards physiotherapy. And afterwards, we will open the floor for questions to every speaker.
The EHDS introduces the patient summary, a standardized digital summary of patients' health, accessible across Europe. And for physiotherapists, this means that when a patient comes from another country or the same country, we have immediate insight into their medical history, the previous treatments, the diagnosis, and medications. And it also means that we have to share our own patient summary from the physiotherapy. This will increase the safety and speeds up the treatment planning and prevents us from spending time collecting basic information. And then we have the data accessibility. An important aspect of the EHDS is that patients have online access to their own health data, as Owe also explained, including the physiotherapists. And Adérito showed us that very few of a lot of physiotherapists don't give this inside information to the patients yet. But it will promote a transparency and patient engagement in their own recovery process. And then we have the data accessibility between health professionals. The EHDS encourages the interprofessional collaboration. Physiotherapists can share information with doctors, nurses, and specialists so that the treatment plans are better coordinated. This improves the quality of care and makes physiotherapists work more efficient and effective. And hopefully it will reduce our administrative workload. And then we have that secondary use. The EHDS allows us secondary use of data, for example, for research, policy development, or education. And for physiotherapists, this will open the doors to innovation. We can analyze the trends and evaluate new treatment methods and base our practice on real data collected all over Europe. Well, so I think we want to go to the questions, but in summary, the EHDS I think offers more insight, better collaboration, and innovative opportunities for physiotherapists, and hopefully with less administrative workload. At the same time, there are challenges such as the technical interoperability and the data security and standardized formats. And I think we must address this together as a sector. So I hope we can join all together to make this work.
Here I'm in the text of the EHDS regulation. I hope this is big enough. 24 para 3, saying that national contact point for digital health. So that those are yes, the contact points that connect to my health.eu. Third countries can join, provided that they meet the requirements, the technical requirements of that infrastructure, that any transfers of personal data that this would implicate, the other requirements, safeguards, are in the end equivalent to those that the member states do. If a third country says, yes, we would like to join this, we would basically do some compliance checks on this. Positive, then we are empowered to adopt an implementing act saying that national contact point of country X, they can get connected. That would also be done via an implementing act earlier. And one word on the procedure there is that one of the steps in adopting the draft act, so in that case, the thumbs up, you can connect for these reasons, a thumbs up, thumbs down on that text. And then the implementing acts are, of course, also public instruments, but we'll also provide that information, let's say, in a consolidated way to public. This is, so maybe you picked up on me saying, oh, this is really interesting. This might be more interesting for neighboring third countries. That was simply because cross-border mobility happening between, say, the EU and the UK, then between the EU and Uruguay, to mention a random other third country. Not that there's any restrictions on who could apply, but it's just to say that and then I should say it's my personal idea, I think it's more likely that the EU might be interested in this than countries who are literally on the other side of the world. So if yes, next steps and what to do if you feel that your decision makers or the Ministry of Health are not that aware of you, simply try to enter into a dialogue with that. I also have to admit that on our side, the prime examples that we were thinking of are, of course, general practitioners, but pharmacies. But indeed, it is relevant for all health professionals, all healthcare providers, including physiotherapists. So there, what I can just say on my side is talk to your ministries, talk to health authorities to make sure that they also have you on the radar, because if your needs are, you are a specific user population in EHDS, so to say, with specific needs, and to be sure that they are taken into account, reach out to them, make your voice heard.
I think we can see that we have a lot of heterogeneity in what member organizations think and use as a patient summary. So we can maybe try to see if it's possible to set a minimum common discipline-specific template for a patient summary, for instance. I would say that we can advocate for digital physiotherapy records in every care setting, because we see that this is not yet true for our member organizations. Advocate for the adoption of healthcare data standards and standardized terminology in physiotherapy, which is also clear that is an existing barrier among our member organizations. Advocate for relevant clinical data access for all physiotherapists, wherever patients receive care, and because we can see that this is still not something that is happening everywhere, and we can try to see if it's possible to advocate for national and EU policies to deliver interoperable and secure data exchange, which is something that is already being answered by this project as was presented before.
Thank you.
Okay, thank you.
Much, Adérito. And conscious of time, I will now give the floor again to Marloes, who will shortly present the next steps.
Thank you all for your participation today. This is just the beginning of understanding the impact of the EHDS for physiotherapists. But we have some plans to go on this topic. So early 2026. So we want the next sheet. There is the summary of actions. Yeah, the beginning of 2026. We want to organize an online meeting where member organizations can share their experiences. So this will be an opportunity to learn from each other and to exchange the best practices and to see how other countries do this or started with this. And in May, we will have our general meeting, and there we have a document about the impact of the EHDS on physiotherapists. And if this document will be approved by the general meeting, we can share that to the member organizations. And then in November next year, we have the Congress in Madrid, and we will further explore the impact of the EHDS on physiotherapy. So we hope we can see you then at one of the meetings, and we can work together on this. So thank you very much for joining, and we will come back to you.